morning, everyone. Before we begin today, I would like to acknowledge the traditional owners of the land we are standing on today, the Whadjuk people of the Noongar Nation, and pay our respects to elders past, present, and future. Welcome and thank you for joining us today. My name is Vilma Fitzgerald, and I am a Senior Research Officer with the Australian Indigenous Alcohol and Other Drugs Knowledge Centre, which is located at Edith Cowan University on the Mount Lawley campus in Western Australia. Today's presentation is one of a series of webinars produced by the Alcohol and Other Drugs Knowledge Centre, which is funded by the Department of Health. We are pleased to introduce our guest presenter, Dr. Stephen Bright, who is a clinically trained psychologist who has worked in the alcohol and other drugs and mental health field for the past 20 years. He is a Senior Lecturer of Addiction at Edith Cowan University in Western Australia and an Adjunct Senior Research Fellow at the National Drug Research Institute at Curtin University. Now, Dr. Bright is a leading Australian voice on emerging drug trends and has appeared on the 7:30 Report, the SBS News, 10 Nightly News, Today Tonight, as well as The Project. He has published research on novel psychoactive substances in the Medical Journal of Australia, Drug Testing and Analysis, and also the International Journal of Drug Policy. I will now hand you over to Dr. Stephen Bright, and he will take you through the webinar presentation, Synthetic Cannabis, Information for Healthcare Professionals. Thank you, Stephen.
Good morning, and thanks for having me. The focus of this presentation is synthetic cannabis as a particular form of new psychoactive substance, primarily because Indigenous healthcare workers have expressed concern, particularly in rural and remote communities, about synthetic cannabis. And I have a number of anecdotes from people that have made contact with me expressing these concerns, though there's limited evidence, there's limited research that's been conducted on synthetic cannabis. So a large bulk of this presentation will be quite generic with regard to the epidemiology of synthetic cannabis and clinical considerations. So the problem with referring to these drugs as synthetics is that many of the drugs other than synthetic cannabis are already synthetic. So the media talk about synthetic amphetamine, synthetic LSD, and you can't have a synthetic drug. But more importantly, when the media talk about synthetics, one of the issues is it creates bias towards something called a logical fallacy, where people believe that synthetic products are more dangerous than natural products, which in turn creates moral panic and often legislative changes that aren't evidence-based, because that there are plenty of natural products that are dangerous as well, including things like asbestos. So just because something's synthetic does not make it dangerous, and just because something's natural does not make it safe. They've in the past been referred to as legal highs, less so now because there's been legislative changes banning most chemicals that I'll talk about. So this is data from the European Monitoring Centre for Drug and Drug Addiction, and they provide one of the best monitoring services for what's happening with regard to new and emerging drugs. So you can see there that in 2014, 101 new drugs were identified by the European Monitoring Centre. So that's about one drug. That's about one drug coming out each week. So there's this exponential increase that occurs and then a bit of a decrease since then. And you can see when we look at the different types of substances that they've been identifying, synthetic cannabinoids in the dark blue make up a large proportion of that, though less so recently. We're seeing more benzodiazepines, and we're seeing more opiates emerging as well. So how do we get to this situation where we've got so many new drugs in the market? We've never been in a situation like this ever in history, where there's so many new drugs entering the market and the drug market has become so tainted. So these new compounds were being developed because they fell outside of the law. The law would catch up, and in turn new compounds were developed, and this cycle of doom, if began to emerge, and we saw the escalation of new substances emerging. Contributing to this as well is something called the iron law of prohibition. So when a substance is prohibited, people look at developing versions of the substance or product that are active at much lower doses. So when alcohol was prohibited in the US, people weren't brewing beer; they were making moonshine because it was easier to get across the borders. And similarly, we're seeing a problem at the moment with fentanyl and fentanyl analogs being sold, particularly as heroin in the US and Canada. And it's also possibly a reason why there might be some concern around synthetic cannabis in remote communities, because synthetic cannabinoids are active at very low doses, so sub-milligram doses, so it would be very easy to transport the actual chemical to a remote site and then manufacture the synthetic cannabis there by putting the chemical onto some plant material. So ounces or pounds of synthetic cannabis could be made quite easily and moved into different regions without detection, whereas it's much more difficult to transport pounds and pounds of natural cannabis. So I've kind of given a bit of an indication as to what synthetic cannabis is. It's generally an inert herbal product containing synthetic cannabinoid receptor agonists. So these SCRAs are similar in structure to THC, the active ingredient in natural cannabis, though they were dissimilar enough in chemical structure so that early on these chemicals were deemed legal and able to be sold as a legal product. And you can sort of see the structural similarity there of JWH-018, which was one of the original synthetic cannabinoid receptor agonists contained in synthetic cannabis products, and its similarity to THC. So brief history, it emerged first in the UK in about 2005, took until 2009 for authorities to identify that JWH was the key active ingredient in this product called spice. And it wasn't until 2011 that we saw Chronic, a brand of synthetic cannabis, begin to emerge as a drug of concern in Australia. And at that stage, it was being produced in New Zealand. Western Australia was the first government to take legislative action and ban 7 synthetic cannabinoid agonists, including JWH-018, which was suspected to be in the Chronic product being sold, in addition to a number of other chemicals that were thought to be in the synthetic cannabis products. So the reason that the WA government sort of had this reaction was that on Triple J radio in about April, there were mine workers ringing in saying they were smoking this product called Chronic. It was awesome because they were getting high at work and it wasn't coming up in their urine drug testing that the workplace was doing. And so the government responded by banning these particular chemicals. And as you can see from this early research that we did, Chronic couldn't have asked for better advertising. So the below line shows the news reference volume, so how many media stories were coming out about Chronic, and the top line shows the number of people that were searching Google to buy Chronic. So there's almost a one-to-one relationship. The more the media talked about it, the more people went online to try and buy it. And in fact, I remember reading one story, I think it was in the Sydney Morning Herald. I didn't get a chance to screenshot it to show you because they took it down before I thought to do this. But the story said, synthetic cannabis to be banned in Western Australia in a couple of days. And next to it was a Google ad to the Chronic store, so people could read the story and head straight to the Chronic store and buy their product. In the lead up to the bans, Chronic were very open about trying to get rid of the product they had before the bans came into place, and they engaged with people very openly in Facebook. So this is a screenshot of a real life interaction of the Chronic store interacting with various people on Facebook. The night before the initial bans in Western Australia came into place, a smoke 'em up party was planned to be held in Perth, and it was shut down by police early on. It was moved to another site, shut down by police again as a matter of public safety, according to police. And so everybody went home a bit sad that the Chronic party was shut down, and they went to bed probably thinking, well, while it's lasted. And then they woke up the next day, and very quickly, new products were being sold that were developed for WA that worked around the laws containing new chemicals that weren't JWH or any of those ones that I'd listed. Some, given the time of year and the timing of it all, some stores were having end of financial year sales. So these products were very readily available, and the sale of of it was very overt, using sort of normal marketing tactics that we'd see in any sort of sales of any sort of consumer product. Chronic itself released its Black Label edition, especially for its WA customers, containing chemicals that weren't banned under that first legislative action. And then in August of 2011, on the front page of the West Australian newspaper, there was a story about a man with a pre-existing heart condition that had a heart attack. Now, it's not the sort of story you'd normally see on the front page of the Australian. That was alleged at the time that he was smoking chronic Black Labels. So the West Australian government moved to ban what they believed was in chronic Black Label, which is AM2201. It was just basically the same chemical as JWH018 with a fluorine atom added to it. So it was a way of tweaking the molecular structure of the banned chemical to work around the law. Around this time, that more chemicals were being banned, the producers in New Zealand actually exited the market. They realized that, every time there was a ban, they had to create a new product, they had to throw out their old product, and so they exited the market. But what happened is Chronic became known as the brand of synthetic cannabis in Australia, in the same way we talk about a Bio as a pen or a Hoover as a vacuum cleaner. And so new local manufacturers set up manufacturing and selling what they called Chronic. And the sign on the right of this slide was taken from St Kilda by a colleague, and at that time, if you logged into the iChronic store, they guaranteed 45-minute home delivery in Melbourne. This is an example of a synthetic cannabis product that I test purchased in Victoria in 2016. It was just after the Victorian government had banned a whole host of new chemicals, broad range of chemical groups, and we wanted to see whether this new product contained chemicals that were banned under the new Victorian legislation, or in fact new chemicals were contained in the product. And we found more new chemicals. This was the first time this chemical had been identified in Australia, and the second time that it had been identified worldwide. So as we continue to ban these chemicals, more new chemicals emerge. And unfortunately, it seems that as these new chemicals emerge, they're becoming more harmful. There's evidence that I'll show in a moment that shows that the newer generation of synthetic cannabinoid receptor agonists are far more harmful than the ones that were originally being sold, such as JWH018. So we saw a whole lot of legislative actions, firstly at the federal government level in 2011, the same seven chemicals the WA government banned were banned by the Commonwealth. In 2012, broad groups of cannabinoids were banned, including synthetic cannabinoid-mimetics. No definition of what that is provided. Nobody's ever been prosecuted for possession or possession of synthetic cannabinoid-mimetics or intention to sell these products, but one would assume that it's something synthetic that mimics cannabis. In 2013, consumer laws were enacted banning specific brands of chemicals, particular brands of synthetic cannabis. And then in 2015, we started to see these blanket bans, and so that the federal they banned anything that had a psychoactive effect, excluding alcohol, tobacco, caffeine, medicines as prescribed, herbal supplements approved by the TGA, and food products, because of course some food products are psychoactive. Then at the state level, going back a little way, Queensland pretty much banned everything. They changed the word or to and in their legislation, so that now, so in the past, a drug was considered illegal in Queensland if it was similar in pharmacological structure or similar in effect to an illegal drug. They changed it so it's similar in chemical structure or similar in pharmacological effect, meaning that things like tyrosine, which is similar in chemical structure to amphetamine, though is non-psychoactive and contained in cheese and avocados, is now technically illegal in Queensland, though the Attorney General in Queensland in 2013 was very specific about saying that they wouldn't be prosecuting people for possession of avocados or cheese. In New South Wales, similar to the Commonwealth, anything with a psychoactive effect. South Australia looked at anything with a similar pharmacological effect. WA in 2016 brought in legislation similar, banning anything with a psychoactive effect. And then Victoria was probably the most recent state to bring in the psychoactive effect clause into their misuse of drugs legislation. So what do we know about the use of synthetic cannabis in Australia, and what, as I said, what impact has all this legislation had on both the use of synthetic cannabis and harms associated with its use? So this data is from the Global Drug Survey, and you can see that over time there's a decrease in the number of people purchasing legal high products in Australia. But there's also an increase in the number of people presenting to our emergency departments for treatment in the past 12 months due to the use of these products. So while there's less people using them, they seem to be causing more harm. We've also got survey-based data from the ecstasy and related drugs reporting system. And so this is a graph of the number of people reporting use of novel psychoactive substances. And this is why I highlight that there's an issue when we refer to them as novel psychoactives rather than new psychoactives. And while the EDARS is a fantastic resource for monitoring, price of amphetamine, availability of amphetamine, and all kinds of really good data, the data on NPS is a little bit limited because it focuses on novel psychoactive substances. So if we break down the 2019 data, most of it is coming from people using DMT, which has been around for about 2,000 years. It's used in ayahuasca. There's in the South America in shamanic ceremonies, but it's also sometimes smoked here in Australia in a product called Chenga. The 2C products like 2CB, 2CI have been around since the 90s. So they're not really new products, they're just novel products. And you can see that synthetic cannabis really only makes up a very small amount of those numbers that we were looking at before. If we look specifically at synthetic cannabis, similar to the Global Drug Survey, we see that there's decreasing prevalence of use. And I had an honours student, Larissa Perry, who conducted a secondary analysis of the National Drug Strategy Household Survey data, looking at West Australia versus Victoria. And the reason that she did this was that she wanted to see whether the Act that was introduced in Western Australia in 2015 had any impact on the use of synthetic cannabis compared to Victoria as a control state, because Victoria didn't introduce this legislation until 2017. The issue that we found was that, firstly, as you can see, West Australians were using a lot more synthetic cannabis in the first place, and so it's difficult to use Victoria as a control state in this respect. But you can see that the downward trend is much more significant in Western Australia than in Victoria. Larissa then went on to do interviews with key stakeholders working in the AOD sector. And what she basically found that the reduction in supply and demand of synthetic cannabis in Western Australia was due to the legislation, this psychoactive effects clause, which banned anything with a psychoactive effect, excluding all the things we talked about. However, the stakeholders also said that some other things that were really important were the raids on the shops that were selling it after the introduction of the legislation. And it was very public, it was in the media. And so people saw this, and it might have had a deterrence effect, because, people may have been using it because it was a legal product and they were worried about the impact now of the law. We also saw the end of the mining boom around this time, and so a lot of people using synthetic cannabis in Western Australia were miners. That's why perhaps it was so much higher in the 2013 National Drug Strategy Household Survey data. And with the end of the mining boom, there might have been a decrease in demand. And there was also probably a decrease in demand because there was increasing knowledge among folk that were using synthetic cannabis that the newer generation of synthetic cannabinoid receptor agonists that were being placed on these products weren't particularly pleasant, and they had a whole lot of nasty side effects. And so that may have reduced demand as well. So it's likely the legislation had an impact, but it was mediated by a number of different factors. So now looking at clinical considerations of synthetic cannabis, and to understand I think, the first thing that's important to do when we're talking clinically is to understand, well, why are people using this product? So the Global Drug Survey found that 93% of Australians who were smoking synthetic cannabis would prefer to smoke natural cannabis. And of those who preferred it, of that 7% that preferred it to natural cannabis, they preferred it because it had a more intense effect. They liked the shorter duration. That might have fitted in well with their lifestyle, perhaps at the workplace where they could smoke it at lunch and sort of not be too stoned by the time they got back to work. Some said it was easier to get than cannabis, and others were using it to avoid urinary drug screens. So what about people who were smoking it that didn't prefer it to natural cannabis? So they'd actually prefer to smoke natural cannabis, but they were smoking synthetic cannabis nonetheless. Well, there's specific populations, and so particularly people undergoing urine screening, so military personnel, mental health patients who often perceive it to be less harmful in terms of their mental health than natural cannabis, parolees, people going through family court. Then we've got people who are unable to access natural cannabis. They may have moved out of area to a new geographical region. They don't know where to access natural cannabis from, but they know that they could go online or go to a brick and mortar store where it might be sold under the counter or even over the counter, depending on the store they go to. And there's a question mark that particularly came from Larissa's study around marginalised populations and potentially Indigenous communities. So one of the respondents said, our team have noted when we're going to squats and shooting galleries, there's often quite a bit of packaging from synthetic cannabinoids there, and homeless populations where I think the use of synthetic cannabinoids is higher than the general population, because if you're highly itinerant, if you're sleeping rough, if you're couch surfing around, it might be hard to maintain a relationship with a regular cannabis dealer. But if you know the local shop will sell you this stuff under the counter, then you've got a reliable and consistent source. So this is the only real hard data that we have regarding the use of synthetic cannabis among marginalised populations. Though, as I said, a number of healthcare workers have made contact with me expressing concern that people are presenting with symptoms that don't look like cannabis. They're presenting with agitation, seizures, with withdrawal. They say they've been smoking natural cannabis, so it may be unintentional use of synthetic cannabis, but it appears to be something else going on. And I think one of the initial concerns was, the old myth that cannabis being laced with methamphetamines going around. And I've done the math with Professor Nicole Lee, and it just makes no sense to put methamphetamine on cannabis in terms of the cost, how much it would actually cost to get enough methamphetamine onto cannabis to get any effect from the methamphetamine. And in addition to that, you'd have to smoke several bongs to get any effect from it anyway. So it's highly likely that what was going on is that synthetic cannabis had sort of infiltrated these Indigenous communities, and perhaps some people knew it was synthetic cannabis, some were using it unintentionally thinking it was that cannabis, but we don't have any hard data. This is an area where we need to do a lot more research. So synthetic cannabis withdrawal, it's far more complex than natural cannabis because there's hundreds of different chemicals. We don't really know which chemical the person has been consuming, but in general, it tends to be far more acute and severe than natural cannabis. There's cases of psychosis, quite common, and also cases of seizures that might be associated with withdrawing from particular synthetic cannabinoid receptor agonists. So in terms of that acuteness, I can sort of provide you with a graphical representation of what that might look like. So you can see that the scores on the cannabis withdrawal scale tend to peak, within hours, up to 24 hours after last use, and then taper off. Whereas with natural cannabis, it's less acute. The onset peaks at around 8 days, and so in the past, cannabis hasn't been or withdrawal units haven't taken on patients who are wanting to withdraw from cannabis, because most of our detoxes are set up as 8-10 day detoxes. And if they take someone on day one of a cannabis withdrawal, they'll be discharging right around the peak of the time that they would be withdrawing from the natural cannabis, whereas synthetic cannabis is a different story. And so a lot of my early work in Victoria was advocating to get the detoxes to take on patients who were withdrawing from synthetic cannabis because of the acute nature of it and because of the potential medical complications associated with it. And then once they were taking them on, speaking with nurses working in the withdrawal units, they said the withdrawal was incredible, like nothing they'd seen before. They were throwing benzodiazepines at it, atypical antipsychotics like quetiapine. They said it was worse than heroin for sort of trying to medically manage the patients that were withdrawing from it. And so if you are suspecting that a patient's using synthetic cannabis and they'd like to cease using, I would highly recommend that you support them and advocate for them to get an inpatient detox, because ultimately we don't want them having a seizure in the community where they're trying to do a detox. And I had a couple I was working with in about 2014. One wanted to do an inpatient detox, and one was quite adamant that she wanted to do it in the community with the support of a GP who prescribed her with some diazepam. The male who went into detox did very well. He was discharged at 7 days, and then the female, because she didn't do so well and was unable to maintain cessation from synthetic cannabis, they were able to take her into the unit when he was discharged, so that she would have the opportunity to withdraw as well, and so they'd be able to support each other. The signs of intoxication and withdrawal, it's very difficult to distinguish what's going on here because, as I say, the withdrawal onset is very early, but things we tend to see that are different to cannabis are aggression, irritability, psychosis, nausea, vomiting, seizures. So what about the epidemiology of other new psychoactive substances in Australia? Well, we've got evidence coming out. We don't have a European monitoring centre. We don't have an early warning system in Australia. We're looking at doing something like this, though it's not currently happening. So my colleague, Monica Barrett, who's hidden by the very clever pseudonym Tronica here, was able to get a sample of a drug that was being sold as ecstasy in Melbourne and get it sent to Spain for analysis, where it was identified that it contained 25C M-bone, 4-fluoroamphetamine, and then just a warning on blue light, the drug discussion forum. There is examples of more recent research using wastewater analysis and forensic toxicology to identify what new substances are out there as a bit of a monitoring system. But probably my biggest concern with new psychoactive substances is unintentional use. We're seeing problems in the US with fentanyl analogues being sold as heroin, and there's the possibility that this could happen in Australia. The example of the ecstasy that I showed before being sold containing NPS is another example of unintentional use. I think the main people who are using NPS at the moment are people who don't realize they're using NPS. So with this being the case, it has an impact on our assessments. We need to be having conversations with people about the drug that they're using, drugs other than they're using. So often, AOD workers might not ask about ecstasy because people only use it once or twice a year, but that might be the drug that kills them. And we might need to be having conversations around new and emerging adulterants that people are unintentionally ingesting. Psychoeducation is important. This hasn't worked very well so far, so I've got a little play on words. I think we need to just say no to drugs. We need to teach people about the situation that we're in, teach them about how they can find out what might be in their drugs through things like reagent testing. I mean, ultimately, if we have drug checking in Australia similar to the trial two trials that have happened in the ACT that would help us just say no to drugs. The PEPI model's useful for talking to people about or raising psychoeducation information, where you maintain their autonomy by asking for permission and then eliciting from them what they already know, listening for any misinformation or gaps, providing that information, and eliciting from them what they thought of the information that you presented. So it comes from a motivational interviewing philosophy. The website Erowid is very useful for getting information as well. It's a non-government, not-for-profit site with all the information peer-reviewed by volunteer doctors and psychologists. And this is just an example of their psychoactive chemicals vault. And as you read through this, you'll see it reads sort of like alphabet soup. There's so many new drugs out there, as I sort of had in the start slide. With all these new drugs emerging, it's important that we as clinicians and our clients are able to access information about these drugs. Another resource which is slightly dated is this from the Australian Drug Foundation. However, all of the information it contains is still relevant today in terms of how clinicians need to respond, what we need to do in terms of our assessment. The only thing that's changed is the drugs that we're talking about, because a whole lot of new drugs have emerged since then, but the actual practical information has remained the same. So I've just included a couple of references to some of the key pieces of research that I was talking to. If you want references on any of the specific things that I mentioned, feel free to get in contact with me via email and I can point you to the source. So thank you for your attention today, and I'll pass it back over to Vilma.
Thank you, Stephen. That was really great. And thank you for your presentation. That was very informative. Is there a relationship between media stories and self-reported awareness and, say, first use? So that's my first question.
Yeah, so the research that we conducted, where I showed the Google graphs from, we cross-referenced that with self-reported use data, and it actually does track. You can sort of plot over the top of that. That there was actually, it was a bimodal distribution. There were people that were had reported for use of synthetic cannabis for the first time prior to all the media attention. So there was a large proportion there, and then there was a large group that didn't start using until they heard about it in the media. So we had that quantitative data. I'm not aware of any specific qualitative data that would support that.
Terrific. Thank you, Steve. And we have another question from Samantha. Is there specific testing available for synthetic cannabis?
Testing in, so I guess there's two questions in there. There's the testing of what chemicals are in synthetic cannabis, and that's very difficult to do. There are laboratories in Australia that can do it. And ultimately, you know, the synthetic cannabis that we purchased from Victoria, we sent to Spain for analysis because it was just easier and quicker, and it was only going to cost us $20. And in fact, they didn't charge us anything for it because we found a unique chemical that hadn't been identified prior. And then there's the issue of detecting whether people have smoked synthetic cannabis. There are tests that have been developed to help detect some synthetic cannabinoid receptor agonists, but certainly not all of them. These were introduced by the mining sector as a way to try to reduce demand for the product, but they're extremely expensive. So, you know, somebody working out of a community health service probably wouldn't be able to afford the testing that's required to be able to determine whether somebody's been smoking synthetic cannabis or not. The test doesn't tell you which chemical they've been smoking. It just sort of comes up as a positive or negative. To determine what chemical it is, it then has to be sent, the urine has to be sent to a lab where they do GCMS testing to identify the exact chemicals that the person's been exposed to.
Okay, terrific. Okay. Samantha would like to know, what are the long-term effects of use?
Unfortunately, we don't have any good data on the long-term effects because the drug is so new. In saying that, I can just talk to my clinical experience, and again, you know, an anecdote or even the plural of anecdote isn't necessarily evidence, but something that we observed, it's not, maybe not a long-term effect, but more of a medium-term effect of chronic use of chronic, if you pardon the pun, is that people appeared to have this wasting disorder. So they were losing weight, they were becoming all skin and bone. They'd go to the doctor for tests because the doctors were concerned that it could be HIV or it could be cancer, but everything was coming up negative, and it seemed to be perhaps one particular or several particular synthetic cannabinoid receptor agonists that were causing it, because once we got people to withdraw and they ceased using, after some time, and 6 to 12 months, they were able to put weight on again. I know of at least 3 cases across Australia where that observation has been made.
Okay, true. Thank you, Stephen, and thank you, Samantha, for that question. If you do have any questions, please don't hesitate to contact us. Our contact details are on the accompanying slide that you can see right now. So this is the Alcohol and Other Drugs Knowledge Centre contact details. There's our email, our website, and we also have a newsletter that we release monthly. It's sent to you electronically, so if you want to subscribe to that as well, there's the link. Otherwise, you can go straight to our website and have a look there as well. So thank you everyone for joining us today and being part of this AOD Knowledge Centre webinar, and a special thank you again to you, Stephen, for that great presentation. We really appreciate it. So thank you everyone, and have a great day.